Good morning, everyone. My name is Dr. Ng Ying Shan. Today, I'm going to introduce you through the gynecological scan. All right, so it is a common scenario that you have a lady, 29 years old, Virgo intacta, who complain of right hypochondriac pain, which radiates to the suprapubic region. And on examination, the abdomen is soft, non-tender, and not surprisingly, plan is refer gynae for scan. So one thing that I would like to let you know is that ultrasound scan is not equals to history, physical examination, investigation, and your management plan. So ultrasound is actually an adjunct to help us to find out, to achieve a diagnosis, rather than ultrasound replacing these four fundamental assessment. Why do we need to perform a gynecological scan? So most of the time you want to know, why does the patient have abnormal uterine bleeding? Why does the patient has abdominal pain? You would also want to assess a palpable abdominal lump or mass. You want to exclude ovarian cancer, patients who require fertility treatment, or those patients who has poor pregnancy outcome in the postnatal period. For example, you want to look into the endometrial thickness, whether there's any possibilities of retained POC and things like that. As for fertility treatment, you also want to do ultrasound for those who has intrauterine contraceptive device that you want to confirm the placement or during your follow-up. So what are the scans that we can do in gynecological patients? So commonly known as TAS, TBS, which are your transabdominal scan, transvaginal scan, a 3D scan, and also a saline-infused hysterosonogram. I'm not going to cover much about 3D scan because Dr. Rafa is going to talk about it. About saline-infused hysterosonogram, it is not commonly done in the clinic because first, it's going to wet everywhere. So the idea of doing a saline-infused hysterosonogram is you put in a catheter into the uterine cavity, and then you infuse with fluids. As the uterine cavity is distended, you will be able to see more detailed structures intrauterine in the cavity. So the commonest things that we do are transabdominal scan and also transvaginal scan, which I'll be focusing on these two modalities. So whatever scan that you do, so please remember to have a chaperone always. So what's the difference in between abdominal scan and a vaginal scan? So when do we actually need to do an abdominal scan? So when you need a good overview, you need to know what is it. So I would always advise to start with the abdominal examination and then a transabdominal scan before you proceed to a vaginal scan. So in an abdominal scan, you will need a full bladder, and the probe has a lower frequency, which gives you a poorer resolution, but you can have a very good overview, and the patient is in a supine position. Whereas in a vaginal scan, you need to empty the bladder. The probe is usually a high frequency probe, and you can get a better resolution, but you cannot see the overall picture. What does that mean? Meaning that if you have a patient with a 20-week size mass, if you do a TBS, you will not be able to see up to the fundus. But if you do a TAS, they will be able to see what is actually the mass extending up to the umbilical region. And also for vaginal scan, how about those who is a virgin? It will be difficult for you to perform a vaginal scan. And the position will be in supine or lithotomy position. And most of the time, you will require a pillow under the buttock. So this is why you will need a full bladder, because the bladder is actually the bladder actually helps to highlight out the pelvic organ. It also serves as a landmark, as you can see from the picture on your left. So that without a bladder window, you can only see intestinal gas around, and you cannot really see what are the organs behind. But with a full bladder, appropriate distended bladder, you can actually see the vagina, you can see the pouch of Douglas, you can see the uterus, and also the endometrial thickness. And in very good, in thin patient, and with a filled bladder, you can actually also see the ovary, and as you can see here, looks like polycystic ovary. This is the uterus. Again, you can see the endometrial lining, the cervix, and also the vagina. All right. So when we talk about gynae scan, what are we actually scanning? So you need to know what you want to scan, because what the mind doesn't know, the eyes doesn't see. So we have to see the uterus, you are assessing the cervix, you are assessing the endometrium, as well as you are looking at the ovaries. If you can see a distended fallopian tube or a distended tubular structure, then it means most of the time it is a diseased fallopian tube. You also would like to look at the ANISA. Is there any special mass? ANISA mass to suggest like things like ectopic pregnancies. You also want to know whether there is any free fluids or not. And also the adjacent organ, such as the kidney, you would want to know whether there's hydronephrosis because of the compression of the mass. And sometimes you can also see some dilated bowels, but we are not trained to do ultrasound on bowels. So for the uterus, you will need to know how to measure the uterus. This is how you measure the total length of the uterus. And this is how you measure the anterior posterior of the length of the uterus. These are in a sagittal view, and this is actually in a transverse view. All right. So the normal size of the uterus is the rule of 3 to 1, 3 times 2 times 1 inches, which is around 7.5 times 5 times 2.5 cm. And you need to know about the position of the uterus. Why is it important, especially when you want to perform a DNC or you want to insert an intrauterine contraceptive device? Then you will need to know, should your uterine sound direct to the anterior or to the posterior? Okay, so if you look at the anteverted, antevert means that the axis of the cervix to the axis of the vagina, whereas antiflex means the axis of the cervix to the axis of the uterine body. So this is an anteverted, antiflex, retroverted, and retroflex. Next, how are we going to measure the ovaries? So this is the ovary, the pictures of it. Then you can measure the total length, the anterior posterior, and then you need to rotate your probe 90 degrees to a transverse measurement. I'll show you how to rotate your probe later. And the normal size of an ovary is 3 times 2 times 1 cm. So if you do a scan and you see a cystic lesion within the ovary 1 times 1 cm, most of the time it is actually just a follicle. So do not be worried about, because it is still within the normal size of an ovary. Okay, so do not jump and say, oh, this patient has an ovarian cyst. Okay. Orientation is very important in doing performing an ultrasound scan, no matter you are performing a gynae scan or what obstetric scan or what. So always look for the marker on your probe. As you can see, this transabdominal scan, you can see this probe, there's a small marker there. This one, we will always point towards the head, the patient's head, whereas this end, we will point toward the suprapubic area. So that is the point that it will show you. This is cephalate. Cephalate is on the left, and the caudal is on the right. Whereas for transvaginal probe, there's also a marker on top of here, which I will show you in a while. Okay, so now I'm going to talk through you the orientation of doing a transabdominal scan. So as you can see, the marker, so this marker is actually pointing to the patient's head, and the other side is pointing to the pelvis. And this is what you can see. So this is the bladder, and this is the uterus. I'll go through with you about this image in a while. So as you can see, this marker is pointing towards here, towards the head of the patient. Okay. So please do not put your probe at the abdomen. So this is what I mean. So ignore this scope and this instrument here. Just look at what you do. If you put your probe at the umbilicus area, so you are only going to be able to see the intestine. So this is what happened if you put your probe at the umbilical area. So the uterus, ovary are actually a pelvic organ, which is below the pelvic brim. So instead of putting your probe here, you should actually put your probe here at the suprapubic region, means above the pubic bone. So if you can see, when we are lying down, the abdomen curves something like this, somehow like this. So when your probe will automatically be pointing towards the head of the patient. So you cannot really see well in the vagina, the cervix and all to help you to guide you. And even the bladder also you cannot see properly. So how are we going to change this? So you should tilt your probe towards the pelvis. Okay, go into this direction so that you can see your landmark properly. And this is what happened on the coronal view of it. So this is how it is supposed to be from this direction. Okay, instead of going that direction, you should go from this direction. Okay, so I'll go through with you about the image. So you can see this is your bladder. This is the 3 lines of your vagina, because vagina is a muscular layer and it will collapse and become this 3 lining, as you can see from here, 3 lines here. All right, then you will see the cervix. Okay, and then after that, you will be able to see the uterus, the outlines of the uterus. Uterus is always behind the bladder. And this is how you measure the anterior posterior diameter and also the length of the uterus. And then subsequently, you will trace the endocervical canal, and this is the endometrial thickness. Then you will measure the ET. All right. And then this area is your pouch of Douglas. All right. So just now, I hope you can see better. All right, with this or this marker here. All right, so let's look at the picture on the right side. So this is the bladder. Okay, this is a transverse view. And then this is a transverse view of your uterus. And this is the endometrium. This is the right. Remember, I always turn the marker to the patient's right, so I will not be disorientated. And then this is the left anexa. Yes, there is something abnormal on the left side, but never mind. Complete your assessment first before you focus on the abnormalities. And then this area will be the pouch of Douglas. So your eyes is not just to see the uterus, but you also have to see outside the uterus what is happening. Okay. All right. This is how you measure the transverse diameter of the uterus. Okay. So let's look through what you will see. Okay. Let's look on the video on the left. Okay. At the sagittal, you sweep it to the right. Okay. And come back to the center. If you realize, I actually tilt my probe towards the pelvis. This is what you will see in real life when you sweep it to the right. Okay, then you sweep it back to the center, to the midline. Then now you sweep it to the left and you come back to the center. So this is what you see. You sweep it to the left. All right. There's a mess there. There's abnormalities here. Do not straight away focus inside there. Come back, complete your assessment first before, or complete the assessment of your uterus before you focus on the abnormalities. All right, otherwise you will get distracted and you might miss out something. So sweep to the left and then come back to the center. All right, then you have finished examining your sagittal view of your uterus. Then you measure, take whatever measurement that you want. So this is the bladder, the uterus, cervix, and the vagina. Okay. And then after that, you sweep into the transverse view. Okay, see the marker is supposed to be here. It was top and I turn it 90 degrees so that the marker points to the patient's right. And I sweep from the top to the bottom. So this is how we tilt. All right, this is what you will see in real life. So you switch. Okay, so that is the patient's right looking at the marker, and that is this left. So there is abnormalities on the left. So I will still complete sweeping from the top to the bottom first and examine the uterus and then examine the anexa. Then only I focus to this abnormal area. Okay, so always do it in a systematic approach. So how about transvaginal scan? So if you can see here, there is actually a small marking. All right, so that will be telling you this. You always have to remember where is the marking. Okay. And I would also want to tell you it is a little bit important to know how to actually prepare the TVS probe. Okay, so as you can see, most of the time we use condom, but in fact, actually there is a medical protective cover, which is just at a dome without this bubbling up here, like a condom. So most of the time, the beginners has an issue is they just they did not empty the air here. So that's why the transmission, when you have air bubble in between your probe and also the target organ, then you will have a lot of artifacts and you cannot have a good image. So this is how I would do I will prepare my TVS probe. Okay, some people may actually pour this gel into the probe, into the tip of the condom, and then only put the condom on top of the probe. But this is how I will do it. Okay, so that is the place, that's the empty dead space that I'm saying that you might actually cause air. See, there is actually no air bubble up there. All right. Even if you have air bubble there, never mind, you just adjust, you make sure you wear a glove and then you just adjust because the gel is down here, right? You just need to push up the gel so that it eliminates the gap as air bubble inside. All right, there you go. Then you are ready to do a transvaginal scan. Okay. So this is a picture to sort of explain to you why we need to put a patient with a pillow, especially when we are scanning a patient with an anteverted uterus. Anteverted uterus meaning that the uterus is actually defected to the front. So a lot of people thought that, okay, you put your probe inside the vagina and you go straight 90-degree inside. All right, it's actually not correct. Most of the time, you will be in a standing position. So your probe has to go down because the vagina is pointing posterior. So when you point posteriorly, when you go in, you can only see the rectum. When you have a uterus which is anteverted, you need to actually push your probe downwards to the floor so that you can actually see the fundus of the uterus. All right. So as this is a coronal view, as you can see, this is your ovarian fossa. So you can see the iliac vessels over here. This is the external iliac and this is the internal iliac. So the ovary just overlie on top of it. And when you put your probe at the center, you actually need to shift your hand. This is the uterus. You need to shift your hand to the patient's left for you to able to see the patient's right ovary. Okay. So again, why do we need a pillow? So you see when you put a pillow, okay, so when you put your probe inside, you are actually seeing the rectum. So how are you going to be able to see until the fundus? You need to push your probe downwards, nearing to the floor. This is what I mean. You push your probe downwards so that you can actually see the fundus and the outlines of the uterus. So this is actually the correct angle of going in. Okay, and then you sweep left and right to see the lateral side of the uterus. But how about the ovaries? How are you going to see the ovaries? Remember, the ovaries is actually posterior to the uterus, right? So when you want to examine the ovary, you actually have to put your probe upwards and then you swing left and right, pointing to the pelvis, okay? So let's see what is the image that you will see when you move, okay? See, this is the marker. I always put it upwards, pointing upwards. So as you go in, always go to the lateral. All right. So go in. This is the cervix. All right. This is the uterus. Okay. So this lining is this is the cervix and this is the endometrial lining and this is the uterus. All right, and you can see some cystic lesion over the lower pole of the uterus. This is actually a Nabothian cyst. Okay, so first try to align until you can see a nice endometrial thickness. All right, that is a place that you want to measure your ET, your uterus, which the measurement of the ET, Dr. Wu will explain to you later. All right, so as you shift your probe to the left, you will be able to see this image. Okay. All right. We are going to the left slowly. Okay, then you will meet the ovary. So when you meet the ovary, you need to, this will be the length and also the AP diameter. All right. And then you need to rotate your probe. Can you just look on the left side of the video? I'll just show you how you should rotate your probe. Okay, just rotate your probe 90 degrees. Okay, so you will be able to get this picture. Then you measure horizontally, then you will get the transverse measurements. And you will see the iliac vessels there. All right. If you have difficulties in searching the ovary, find the iliac vessels, then you will be able to find the ovary. Okay. All right. Then after you have examined the ovary, you rotate back to the marker pointing, you rotate back the marker pointing the ceiling, and then go back to the central position. Okay, and now you go to the other side using the same movement. All right, and examine. If you realize I'm actually sweeping upwards, moving my hand up nearing to the ceiling and going down nearing to the floor while I'm in a transverse position. Okay, so this is how it looks like when I move my probe to the other side. There you go, there's the ovary, and I rotate my probe, and you can see the vessels behind here. And then I'm examining the transverse view of the ovary. All right. Okay, so here is the pouch of Douglas. This TVS showing actually a patient with a retroverted uterus. That's why the bladder is actually on this side, and this is the uterus pointing posteriorly. All right. Okay, so now you have actually see the lateral view, you have examined the uterus, and also you have see the ovary. So what you should actually do now is put your probe into a transverse view. Look at the video on your right side, your left side. Okay, see my thumb, I am actually rotating it 90 degrees, and the marker is actually pointing to the patient's right. Okay, so put it into a horizontal view, and then you sweep up towards the ceiling and sweep down towards the floor. Okay, so this is where it is. Sorry, just go back. Okay, then you rotate it and then sweep up, you will see the fundus. Sweep down, you will see the cervix. Okay, up to the fundus, down, you will see the cervix. All right, so this is what you see in real life. So I am sweeping up and down. Okay, so you can see this is the endometrium. This is in a transverse view. Okay, and sometimes if you have difficulties in looking for the ovary, what you can do is, again, you go into the transverse view. And then if let's say it is an anteverted uterus, the ovary should be somewhere behind here. Okay, because the ovary is always posterior to the uterus, so you will be able to find. And you have to pay attention, especially when you are scanning patients for ectopic pregnancy. Look for any adnexal mass at this region, which is somewhere around this region. Okay, and you will be able to identify any weird adnexal mass or mixed heterogeneity mass there. Okay, and then now you go back to the center. I'm just demonstrating to you what is a sliding signs means. As you can see, this is a dynamic ultrasound assessment. Is actually a dynamic assessment. It is in combinations of movement. All right, so you can see from here, okay, this is the uterus. Okay, this is the bowel overlying it. You see how it slides through. Okay, when I push the probe, the bowel is actually moving away. Okay, so you can see this is actually the bladder. I actually didn't manage to show you the bladder earlier. I'll just show you one more time. So this is actually the bladder, which is the anteverted, retroverted that I mentioned to you. Okay. Okay, so where can we find free fluids? Huh? Okay, so for your information, you can actually find free fluids at the pouch of Douglas, where you put your probe at the suprapubic region. You can also find free fluids at the Morrison pouch, which is at your right upper quadrant, and also your left upper quadrant is your splenic renal angle. So this anechoic area, anechoic fluids, anechoic means black color lah, basically. And anechoic area is the free fluids, and you can see some chicken, duck, and some heart. No, it's actually the bowels. All right, these are the bowels that is actually floating inside, and you can see the uterus is actually floating inside the floating in the fluids. So this is pouch of Douglas, and this is the uterus. All right, that's the bladder, and that's the uterus. Okay, so the black color is actually free fluids. All right, so you can see the free fluids in the Morrison pouch. Okay, on the picture on your right, which has been labeled the liver and the kidney. So in between there is actually the free fluids. But not to be fooled by this picture on the left side, sometimes you can see one well circumscribed lesion. This is actually the gallbladder, but this patient does have a lot of free fluids. Okay. Okay, you also have to know about the standardized terminology for ultrasound. For ovary, we are talking about iota. For endometrium, we are talking about IETA. And also endometriosis, we have IDEA. So these documents will be available later in the resources area, and the respective speakers will be talking through to you about how to describe the appearance and how are you going to document, what are the things that you need to look for when you look for ovary, abnormal ovaries, or abnormal endometriums or endometriosis. So my take-home message for you is you need to know why you need to scan the patient, and you need to know what are you looking for. Always do it in a systematic approach, and you need to know your orientation so that it is easier. If you didn't know your orientation, you will never know what you are doing. Documentation is important. You need to write down what you see, what you did not see as well. And last but not least, ultrasound does not replace other clinical assessment. It is just an adjunct, a very useful adjunct, but it does not replace your clinical assessment. All right, with that, I thank you.